Hello, everyone. We're going to get started in just a minute here. Okay. Okay, so I see that it's time, so we'll get started. Hi, everyone. My name is Raj Lala, and welcome to this MASCC webinar on supportive care in cancer during the COVID-19 pandemic. I have just completed my term as president of MASCC, and it's my pleasure to be the moderator for this session today. If it wasn't for COVID-19, many of us would actually be in Seville, Spain today for the MASCC ISO annual meeting, which was of course postponed. So it's very fitting that we are having this discussion today. I'd now like to introduce Melissa Chin, who is the Executive Director of MASCC and is helping to manage this webinar.
Thank you, Raj, and welcome everyone to this exciting and informative webinar on supportive care in cancer during the COVID-19 pandemic. I just wanted to go through a few housekeeping items. Firstly, this session will be about an hour in length, and it is being recorded, and it will be available on the MASCC website following the webinar. So in the event that you have to step out, or if there was something that you may want to rewatch, that will be available afterwards. On the bottom of your screen there is a chat and a Q&A function. If you do have any questions, which I see that there are already questions being asked, that we do ask that you put any questions relating to content in the Q&A function there. And we will do our best to respond to any of those during the webinar through typed responses. And for those that we may not get to, we will respond to them verbally at the end, time permitting. If there are any technical issues that you're experiencing, please do let us know in the chat box, and we'll do our best to try and triage those for you. The other thing that I just wanted to mention then is all the questions, of course, that were pre-submitted, we will do our best again to address them at the end of the webinar. And so before we start, I wanted to take a moment to acknowledge the sponsor of this webinar, Alira Health. Thanks to their support, we are able to offer this webinar free to everyone. I'd like to introduce Chris Rayo, who is the Vice President of Clinical Development for Alira Health. He helps to lead their CRO practice with a focus on oncology supportive care research.
Thanks, Melissa. I'd like to welcome all of you and really looking forward to an interesting discussion today. Just want to say on behalf of the Alira Health team, we're proud to support today's webinar. We know that it's going to address some very important issues for both cancer treatment providers and especially for patients and for those of us involved in oncology supportive care research during the COVID-19 pandemic. So as an organization which has been devoted to oncology and oncology supportive care for about 20 years now, I think we can all agree on the Alira Health side, but even the larger group present today, that really oncology supportive care research and novel therapeutics are more important than ever, along with novel cancer treatments. So really looking forward to an interesting discussion and a meaningful discussion today. And just a quick note about Alira Health, for those of you who may not have worked with us before, we're a team of researchers, regulatory and clinical experts, scientists, and healthcare strategists who assist companies to bring their products from concept to market, and especially focused in oncology and oncology supportive care. So I just want to thank again the MASCC team for their continued collaboration. Especially want to thank all of our panelists for being here today and welcoming all of you to this discussion. Thank you.
Thank you, Chris. So we're now going to go on a journey to learn about the impact of COVID-19 on supportive care in cancer across the world. We're going to start in North America, make a couple of stops in Europe, and finish in India. And we'll have a global panel discussion at the end where we'll address some of the questions that we've already received and also try to address any additional questions entered in the Q&A box. So it's my pleasure to introduce our first speaker, Dr. Breffney Hannon. Dr. Hannon is a palliative care physician and site lead at the Princess Margaret Cancer Center in Toronto, Canada. She leads the Clinical Research Fellowship in Palliative Care at the Cancer Center and is also research lead in the Division of Palliative Medicine at the University of Toronto. Dr. Hannan.
Hi there, good morning, and thank you so much, Raj, and the MASCC group for the opportunity to speak to you this morning about our palliative care team's experience during the COVID-19 pandemic. Thanks, Melissa. You can move the slide on and again. So over the next 8 to 10 minutes, I'm really going to try to stick to my time to give everybody an opportunity to share their experiences. But I'm going to try to describe our palliative care service at the Princess Margaret Cancer Centre in Toronto, to outline how our team has responded to COVID-19 in terms of our clinical, education, and research activities, and finally talk about some of the lessons we've learned from COVID so far. Next slide. So just to start off and show you how Canada has been affected by COVID-19 so far, we've had just over 100,000 cases in Canada since January, and the kind of royal blue colour there towards the bottom is Ontario, where the Princess Margaret Cancer Centre is situated, and we've had almost 34,000 cases in our province so far. Next slide. At the University Health Network, which is a group of 4 hospitals, of which Princess Margaret is one, it has 2 acute care hospitals and 1 rehab facility, as well as the Princess Margaret, which is the only tertiary cancer centre in Canada. We have been relatively spared compared to some of our colleagues across the world in terms of exposure to COVID-19. Since January, we've had 315 inpatients across the 4 hospitals with COVID-19, and luckily only a handful of those have been at the cancer centre. That said, much like the rest of you, so much attention and thought went into how we would address COVID-19 over the past several months to really set us up for what might be coming down the tracks. And in particular at the Cancer Centre, there was a lot of stress and anxiety about the potential impact of COVID-19 on our patient population in terms of morbidity and mortality in a particularly vulnerable group, as we learned from other areas. Next slide. So just to give you a little bit of context for what we do with the Princess Margaret in terms of our supportive care program. So palliative care provides support across 3 areas at the Cancer Centre. We have an acute palliative care unit, where we provide short stay care for complex symptom management. For inpatients on our medical oncology, radiation oncology, and hematology services, we also have an inpatient consultation service. And we have a large ambulatory clinic, which is the source of most of our early palliative care research and studies, and which sees about 1,400 new patients per year. New slide. So I'm going to spend the next couple of slides just talking about each of those 3 areas individually, because each had a unique response to COVID-19 and unique challenges that we needed to face as a group. So right from the very beginning, we were tasked with trying to keep our unit and our hospital as COVID negative for as long as possible. But at the same time, we really needed to prepare for a potential surge and what that would look like in terms of patient volumes and needs. So from the COVID negative perspective, straight away, we had to do a lot of screening and testing for patients before they ever came to our units. And for patients who had symptoms suggestive of perhaps having COVID, they were first brought to what was called a patients under investigation unit, where they stayed for a number of hours, had their COVID testing done, and if it was negative, they were then moved to our palliative care unit. Patients who did not have any symptoms, we still took an abundance of caution. They were admitted to a single room. They underwent testing and were isolated until their testing came back as negative. We have 12 beds ordinarily, but we did need to consider how we could escalate those beds and add up to an additional 8 to 10 beds if needed. One of the biggest challenges we faced right from the very beginning was the strict no visitor policy that was imposed at the hospital and the impact that that had on our patients, because a lot of our community-based patients really didn't want to be admitted to hospital if their family members couldn't be around them and couldn't stay with them. So this had a huge impact on the number of admissions, but also on the complexity of how we cared for those patients who needed to be admitted. And we needed to come up with some novel ways for our patients to communicate and interact with their families, as well as for ourselves as the healthcare providers to provide that day-to-day, hour-to-hour updates to families without being overwhelmed. We had some issues with drug shortages, although thankfully very minimal, and usually around drugs like midazolam and fentanyl. And we also had to consider our staffing, which was a big issue. So as I mentioned, we've got staff working across multiple different areas of the Cancer Centre. And what we learned from our partners at another acute hospital was that at that site, one person became infected with COVID and they inadvertently exposed themselves to the entire palliative care team, who then had to go and be tested and isolate for 2 weeks. So we couldn't let that happen at our center. And so we divided ourselves into 2 distinct groups, one which was dedicated to looking after patients on our palliative care unit, and one looking after our inpatient consultation service to minimize crossover and risk of exposure. Now that we're entering into the recovery phase, we still have ongoing screening and testing for all admissions. We're still battling with these ongoing visitor restrictions, although trying to relax them. And we are now seeing a gradual increase in our volumes to our palliative care unit. Next slide. On our inpatient consultation service, we saw almost the opposite. So there was a rush to discharge patients home as soon as the pandemic was declared. Patients really wanted to be in the comfort of their own homes and around their families. But this put a lot of stress on our consultation service, who really took up the baton of coordinating discharges, coordinating equipment, supplies, community resources, and medications for these patients. Because there was a concern that our acute partners were going to be overwhelmed with patients, a lot of patients with cancer who were admitted at those acute sites were decanted over to the cancer center quite rapidly. So we saw a big increase in our volumes to about 120% of our pre-COVID volumes, which again put a lot of stress on our consultation service. And bearing this in mind, as well as trying to maintain, the health and safety of our team, we began to consider what criteria we might use for patients who continued to be seen in person versus those for whom we could provide virtual support. And we also worked with our partners at the other acute hospitals, as well as the cancer center, to develop some symptom management guidelines, some order sets, and goals of care templates for non-specialists to use, bearing in mind that if there was a surge, our teams were not going to be comprehensive enough to provide all of the care needed to all of these sick patients. Now we're seeing a reduction in our volumes back to our pre-COVID numbers, but we do have a growing acknowledgement and acceptance of the importance to standardize how we communicate and how we document goals of care discussions for the future. And it's given us a pause to really start to consider staff support and wellness on an institutional level. Next slide. In our clinic, as I mentioned, we've got a large ambulatory practice at the Princess Margaret, which is the site of our early palliative care program. And pre-COVID, all of those patients pretty much were seen in person, where they underwent a comprehensive in-person consultation with the multidisciplinary team. And this was how we continued to see patients. So we had no choice. When the pandemic was declared, we had to switch immediately from in-person to telehealth visits. And this was an extraordinary feat where we managed to convert 90% or more of our visits to telehealth within 2 weeks of the pandemic being declared, and having really had no infrastructure to do that before. Although this was wonderful, it had a huge impact on the whole team. So it impacted our staff, who were used to working as part of a collaborative team together in a one clinic space. Many of us were now working from home. We didn't have the support that we were typically used to from each other. We needed to communicate appropriately, rapidly, and in the moment with one another. And we also needed to consider the impact on our patients, who were not expecting this to happen and thought that they would still come and see us in the clinic. So many of them had issues with technological challenges, with connectivity, but it was really important for us to continue to support our patients, even those who were not affected directly by COVID, so that they understood we were still there to support them, although in a slightly different way. And our practice changed quite a bit, obviously, moving from in-person to virtual, where normally we would collect things like ESAS and ECOG in person when patients come to the clinic. We now had to look at virtual ways to collect those patient-reported outcome measures. Now that we're in the recovery phase, in many ways, this is more challenging, because now we're trying to come up with a roadmap for how we gradually reintroduce in-person visits, while still considering the broader impact of all of these patients coming to the hospital on a daily basis. How do we socially distance these patients? How do we protect them from other patients in the hospital? How do we minimize time spent in the hospital, sitting in waiting rooms, moving between different clinical areas? And so we're now exploring some longitudinal virtual models of care, which is a really exciting development and something that we're really looking forward to exploring further. Next slide. At our core at the Princess Margaret, we are an education and a research centre, and it was very important for us to try and maintain or look at novel ways to continue this work. After a brief break at the beginning of the pandemic, we've now moved over to virtual journal clubs, teaching and educational rounds. And of course, like many other people, we're recognizing the challenges with teaching and observing learners using virtual technology rather than being there in the moment with them. In terms of research, again, as with many centres, all non-essential on-site research activities were suspended when the pandemic was declared. And over the past several weeks, we've started to see a gradual phased restart in tandem with our clinical work and with disease site prioritisation. But we are still navigating these challenges with virtual recruitment and consent of patients when they're not physically coming to the cancer centre, as well as how we systematically collect and document our outcome measures. Next slide. What lessons have we learned? Well, too many to mention in 8 to 10 minutes, but I think the ones that jump to mind are, one of the things was, how do we balance all of this surge planning and planning for the worst while also continuing to support our patients who had ongoing issues with symptoms and cancer-related concerns? COVID-19 really did expose our reliance on in-person visits to interact with patients and our partners, as well as to complete patient-reported outcome measures. And it's been a really exciting time, actually, to look at these opportunities for how we can develop virtual models of care, not just for pandemic planning, but how we can use those in the future to complement what we have been providing in person all along. We quickly learned how important it was to communicate frequently and clearly with all members of the team as our response to the pandemic was evolving from hour to hour and day to day, and the importance of supporting one another as our roles and our responsibilities changed. And what's been really heartening is to see how our institution as a whole is really starting to recognize the importance of staff wellness moving forward into the post-COVID era. Next slide. I want to finish up by sharing this quote, which actually has nothing to do with COVID-19 and was a quote from about 30 years ago during the George W. Bush regime in the US by one of the Secretaries of Health and of Home and Healthcare. And he said, "Everything we do before a pandemic will seem alarmist. Everything we do after will seem inadequate." And I think it really sums up how we've all responded, so dramatically to this pandemic. But hopefully we come out the other side stronger with more novel ways of communicating with one another, for sharing information across countries, cities, continents, and hopefully moving into a more virtual world where we can all work together in a more collaborative way. Next slide. And I want to finish by saying, hopefully I get to see many of you in person next June in Seville. And perhaps more importantly, I'm going to put a plug for Toronto 2022. Hopefully you guys can come and explore our city then. Thank you so much.
Thank you so much, Dr. Hannon, for a really, really informative and nice presentation. So as I mentioned, we're going to continue on to the next speaker and hold questions to the end. But if you do have questions during the seminar, please feel free to enter them into the Q&A box at the bottom, and we'll try to address some of them either during or after the session. So our next speaker is Dr. Paolo Bossi. Dr. Bossi is, I'm sorry, I skipped Dr. Scate. So our next speaker is Dr. Florian Scate, and Dr. Scate is a medical oncologist and head of the Interdisciplinary Cancer Course Department at Gustave Roussy Cancer Campus near Paris in France. His department combines supportive care, ambulatory care, and critical care in oncology. Dr. Scate is also Vice President of AFSOS, which is the French-speaking Association of Supportive Care in Cancer, which is an affiliate of MASCC. Dr. Scate.
Thank you very much, Mr. President. I'm dreaming of having the same barb as Paolo Bossi, but I have not, I'm so sorry. So next slide, you can see my disclosures. Okay, thank you. So first of all, I want to show you the first wave that we had in France between 15th of February, 25th of February, and running to 11th of May. You can see the France lockdown in February 18, and you can see on that wave, following the same number of patients with COVID, the number of beds opened in the ICU with moving from 6 beds to 28 beds for COVID patients. At the same time, we went from 22 beds open for COVID patients, and we moved to 68 beds open in our Cancer Comprehensive Center. So next slide. Thank you. You can see the wave in France. So Paris area was the first point of visions in France with the COVID. And as you can see on the curves, on the plain curves, you can see the occupation of beds in hospitalization for patients with COVID. In red is the ICU beds, and you can see in the dashed curves that in Gustave Roussy, we had a great effort to fight against COVID in the ICU, in the reanimation unit, because a lot of patients came in the unit, and we moved from 10 beds of ICU, and we moved to 28 beds in our institution. So it's more than what we did in France. Next slide. Of the 236 patients that we had with COVID, we can see how we managed our patients. During the 2 months period, we had more than 7,000 patients managed in our hospital. You can see that we had 1,300 patients tested by RT-PCR and only 12% of patients with COVID. We excluded from our study, but I will just show you this slide for the results. We excluded 19 people, patients without cancer, because for the first time in our history, we welcomed patients without cancer in our comprehensive center. So it was a change of paradigm of our department and of our institution. We had 137 patients with cancer, and as you can see, the 2 columns, a large majority of them were admitted in hospitalization, and only a quarter of them were managed as outpatient. The symptoms of diagnosis was first of all fever and then dry cough. Fatigue was in the second position, but you can see that we were specifically vigilant to fever and dry cough. The next slide, please. Here is the running of treatments. So in France, we are helping for hydrochloroquine and antibiotics because of Professor Didier Raoult. But we had a lot of trials, and specifically in our institution with antistocin, with tocilizumab, with interesting results. But as you may know, we had a lot of treatments without any real treatment against COVID, and so it seems to be interesting in the ICU patients. The next slide. So to sum up the management in our institution, we had exactly the same proportion of patients in terms of diagnosis, with 12% of our global population tested positive for COVID. We had 11% of patients admitted in the ICU with a death rate at 14% compared to the 18% of patients in France. So it's interesting, I think, that we managed correctly our patients. We had to pay specific attention to frail patients, to patients with hematological disease, and patients with advanced disease and under chemotherapy. We had no problem with patients under targeted treatments or under immunotherapy, but we see in our result that the worst prognosis of patients were for patients with under cytotoxic chemotherapy. Next slide. So as you can see, there are a lot of publications during this short period of 6 months. I did it 2 days ago, and 1,600 publications can be found in the PubMed research. I just show you four of them that I will treat in the next slides. Please, next slide. So the first of all of importance is to protect ourselves, to protect other patients and all the community. Now, first of all, the use of hydroalcoholic solution, then the use of mask and the use of glove if we have aggressive invasive action. Next slide. So ESMO has published big chapter on supportive strategies. And as you can see, I focus here on the thromboembolic events management. And we just remind that we have guidelines to manage patients with thromboembolism, venous thromboembolism. But in the case of COVID patients, we have to be specific attention because most of them will have complication with intravascular coagulation disorders, and many of them are presenting themselves in the hospital with venous thromboembolism. Next slide. We have a lot of guidance. We have a lot of expert advices, but we have one guidelines that we can find in the PubMed, the CHEST publication with, first of all, thromboprophylaxis for acutely hospitalized patients and for critically ill patients. So the proposition, the recommendations are for low molecular weight heparin or fondaparinux over unfractioned heparin and DOAC. But we need to limit the staff exposure, to limit bleedings, to limit drug-drug interaction. It's because we have to be cautious with DOAC, and we have to use it for inpatient, and for thromboprophylaxis, we avoid patients after hospital discharge. Next slide. In terms of curative intent, as you can see, the recommendations, the guidelines are for acutely hospitalized and patients, and they proposed low molecular weight heparin or DOAC if there is no drug-drug interaction. For outpatients, they proposed to use DOAC if no drug-drug interaction in order to avoid the contact with physicians or nurses at home. For critically ill patients, they propose to use DOAC or low molecular weight heparin, and the minimum of treatment is for 3 months, and limiting invasive therapies only to patients with cardiopulmonary deterioration. Next slide. So next step is the digital revolution. Next slide. We published this paper in the European Journal of Cancer, and we managed patients with this application, web application, with nurses collecting and managing, monitoring patients at home if they had any symptom. And then if they have symptoms at home, so the patient will move to the emergency department if they have no symptoms to report, so they were monitored at home. And we used this PRO program to monitor them. It's the same program that we use for patients under oral targeted treatments. Next slide. We also use it for patients with vulnerability, social or psychosocial vulnerabilities. As you can see on that side, we have a decision tree for patients with or not disorders. So we have these 3 colors: alert, green, or orange, or red. And the red is to establish a contact with the patient. Next slide. And I will finish with that. After crisis, we'll have to use, again, the protection with mask, and we are all wearing masks in our hospital. And why not in the restaurant? But it's difficult to eat with a mask. But it's better in France to kiss everybody, but today we stop kissing anyone. Next slide. What is really important is the change of the nurses and the physicians' approach during this crisis. And what we could see in our institution, but I think all over the world, is solidarity and friendship against terror. And that's what we can see, because we had a contest with photos during this crisis, and every day we have a lot of photographies shown in the website. And the last one, thanks to all of us, and we just have to be all together, is, I think, the message of MASCC in terms of supportive care. Supportive care makes excellent cancer care possible. And what we try to present to you today is that we have to work all together over the world to fight COVID and to fight disorders for patients under cancer. Thank you very much.
Thank you so much, Dr. Scate. That was really an excellent presentation and wonderful pictures showing really the sense of teamwork that is so important during this time. So now we go from France to Italy, and our next speaker is Dr. Paolo Bossi. Dr. Bossi is a medical oncologist and associate professor at the University of Brescia in Italy. He is having a very strong commitment to supportive care, both in clinical research and education, with a focus on the treatment of elderly cancer patients and toxicities induced by immunotherapy. Dr. Bossi is also the secretary of NICSO, which is the Italian Association of Supportive Care in Cancer, which is an affiliate of MASCC. Dr. Bossi.
Thanks, everybody. Thanks, Dr. Lalic. It's really a pleasure to be with you today. And I confirm what Florian was saying, that it's really difficult to kiss wearing the mask. However, also in Italy, not only in France. However, next one. This is my disclosure of interest. Next. So, pandemic in Italy, we faced exactly an acute phase just 2 months ago. And in the period between February and April, there was really high transmission and disease rates, particularly in northern Italy, that is the province where I live and where I'm a physician. However, there were also limited availability of nasopharyngeal swabs, and this was really somewhat that concerned us as a community of physicians. And we know that overcrowded hospitals became carriers of infections. And so as oncologists, we have to take pragmatic actions to preserve, especially the more vulnerable cancer patients. Next. So during the acute phase, we need to reorganize the cancer care in order to take these 4 actions. The first one is the most important one, that is to preserve the safety of our patients. But also the second one is important because we need to keep healthcare professionals away from any infections, because this is really risky for people who can transmit the disease and then can also become infected. But there is also the need to maintain the treatment intensity, in particular when we aim to have a curative intent treatment. But it is also important to prioritize quality of life. So in the next slides, I would like just to open a parenthesis. Next one, please. Because parentheses on prioritizing, for me, it's such a difficult word. I don't know what you think, but I do think that sometimes as oncologists, we were asked to prioritize your patient and to treat, just to treat only the patient, or start before starting to treat the patients that have the highest possibility of a cure, because you treat them with curative intent. However, in my opinion, as oncologists, we have quality of life as the maximum priority of our work, as well as increasing survival, because this is our work. And therefore, supportive care should be embedded in every phase of cancer care, in as much it is aimed to improve quality of life. So this is our priority, also in the COVID acute phase. Next. During the acute phase, we had to reorganize the cancer care in an hospital setting, where, as I have already told you, we have limited access to nasopharyngeal swabs. So we learned to triage our patients, and I will explain after that how we triaged our patients. But we need also to keep the patients at home as much as possible, and to connect the patients with us with all the tools that we have in our clinical practice. Next. What I mean when I speak about triage during the acute phase. Triage is essentially looking for symptoms, to ask the patients to indicate us which kind of symptoms they are suffering from. And you see in the slides some of the most important symptoms that you could associate with the COVID disease. But you know, in cancer patients, I think that you agree with me, these are common symptoms. So it is sometimes really difficult to be able to understand what is a symptom that is linked to the virus, and what is a symptom linked to something else, in particular to cancer or to complication due to treatment. Next one. this is this is what we have an experience just limited of the oncology department in my hospital. In this 2 months period, during the acute phase, we had a contact with 1,000 and about 200 patients. And thanks to the phone triage, we had the opportunity to find out 30 patients that was COVID positive and to put them directly in the emergency room and to take care of them with our infectivologist. All the other patients assessed our day hospital and assessed the triage. The triage was able to find out more than 300 patients with symptoms. 70 of them stopped the treatment because these symptoms were possibly related to COVID, and these patients were quarantined, and we asked them to stay away from any other people for at least 2 weeks. But however, 1,000 of all the patients that we had in our starting our access to the hospital continued the treatment, and this 1,000 of patients had no symptoms and had no COVID disease. And of these patients, I may confirm that the ones that behave better was the ones treated with immuno and targeted treatment. Next one. But what about the post-acute phase? Because now in Italy, we are settling in the post-acute phase. And we know that there is a knock-on effect and that there could be an increase in advanced care diagnosis. Because in the last 2 months period, we observed a clearly a great reduction in the number of patients that assessed as a forced visit, as forced access to our oncological department. This could be due to the fear of the patient of entering an hospital, in particular a department where COVID could be very risky, or could be due also to less availability of beds in other departments of our hospital that possibly could send patients to us. And moreover, there are also less access to follow-up visits because all of us got slower in the follow-up visits. And so we are expecting late diagnosis of recurrent disease. So for all these, we expect that this will reflect into possible worse survival of cancer patients in the next months. This is only an hypothesis, we know, but it's something that we should be ready to tackle. Next. And what about the post-acute phase? I would like to take this sentence, that is a sentence that the mayor of Chicago told to President Obama just after the economic crisis in 2008. He told him that you never want a serious crisis to go to waste. And what I mean by that is that this is an opportunity to do things that you think you could not do before. And so what are the things that we could not do before? Absolutely test the patient and triage, to learn more to have a home care-based management of oncological treatment and supportive care, to think multidimensional solutions, to reorganize the follow-up, and also importantly to pay attention to psychological issues. Next one. In the next slides, I would like to put attention only to 3 of these points. The first one is the home care project that we have for oncological treatment, because we are involving a team composed by oncologists, nurses, and pharmacists, and trying to get directly the drugs taken by mouth to the patients at home, so reducing the risk of hospital-acquired infections, possibly increasing the therapeutic alliance. When the physician and the nurse visit the patient, you may increase the satisfaction of the patients and the alliance that you create with the patients, and possibly also to improve the treatment adherence. But in the next slides, you may see that the home care project, next one, is also useful for supportive care at home, because the use of biphosphonate, hydration, or intravenous therapy like antibiotic, antiviral, antifungin therapy, but also painkillers can be administered at home. But also we need to keep the patient at home and to assess their symptoms directly. So as already said by the previous speakers, the use of patient-reported outcomes is crucial, but also the cooperation with the nurse that can offer scheduled phone call to the patient to assess their symptoms and to give the first suggestions in order to improve them. Next one. But we think we have to think outside of the box by multidimensional solutions with, for instance, telemedicine and all the e-health approaches that can acquire real-time information from our patients and directly collect them and transmit to the desktop of physicians. Through these approaches, we can also perform ad hoc analytics with the clinical decision support system, CDSS, it is called, that can increase the number of data and so creating a sort of big data to improve our approach to symptoms of patients at home. But we are also able to monitor symptoms through web-based application, but also through wearables systems and tools. We may perform ECG. We may also motivate and engage our patients. And so moving from a passive patients at home to an active patients in rehabilitation and in telling us their symptoms. This is really a challenge, but is an issue that we can perform also in our everyday clinic. Next one. And what about clinical trials? We have to reshape the way of proposing clinical trial participation, because from one side, we have to put attention to the risk of infections, but from the other side, we have also to keep the attention not to reduce, not to preclude our patients the possibility of receiving new drugs. And clinical trials, this is another important thing, so should be also focused on some logistical issues. This is, for instance, how to better take care of our patient at home. We have different endpoints in this regard that are quality of life, cost effectiveness, patient and caregiver satisfaction, and so on. Next one. So at the end of this brief talk, what kind of lessons I have learned? The first one is the crisis is a passage towards something new. You know that from the ancient Greek, crisis means something to change, a passage. So this should be our main aim to learn. My main aim is to have learned something from this crisis. And I have also to start reasoning from another point of view, from outside the box, and we need also to act as a community. So I would like to thank everybody and for this opportunity and to have also a nice meeting together. Thanks.
Thank you so much, Dr. Bossi. And I like the expression crisis as a passage towards something new, because really I think this pandemic has taught us all to do things in a new way, and in some ways has forced us to innovate and to really learn, to go out of our comfort zone and try new things. So some good comes out of everything. So moving on now, to our final speaker, Dr. Anant Ramaswamy. Dr. Ramaswamy is a medical oncologist and associate professor at the Tata Memorial Hospital in Mumbai, India. In addition to treating gastrointestinal cancers, he is actively involved in improving supportive care for patients with cancer. And Dr. Ramaswamy is also the treasurer of the Indian Association of Supportive Care in Cancer, which is also an affiliate of MASCC. So Dr. Ramaswamy.
Greetings to everyone across the various time zones that we're in. It's indeed a pleasure to be a part of this webinar organized by MASCC, and it, I think, comes at a very important time. Next slide, please. I do not have any disclosures with regard to this. And over the course of the next 9 to 10 minutes, these are some of the topics that I'd like to cover on COVID and cancer in the Indian scenario. Next slide, please. Next slide, please. Yeah. So since we have a moderator and panelists across the globe, this is just to show that while the pandemic may be the same, we are all in different stages of the pandemic and are trying to find our own solutions to this pandemic for our patients with cancer across the globe. Next slide, please. So this was two of the headlines that were there in major newspapers in India just about a week ago, saying that cancer care has come down and taken a hit during the period of COVID. So when our patients see these kind of headlines, it is actually very distressing. And so what can we do to alleviate some of these concerns is what we look at over the next some time. Next slide, please. So this is data that was published from our institute approximately 3 weeks back, where despite the COVID epidemic, we were able to do approximately 520 major cancer surgeries over a period of 5 weeks. As you can see, a majority of these were higher grade surgeries, and there was an acceptable complication rate. We did note an increased rate of complications in patients who are more than 60 years. This is just to show that while COVID is an issue, I think continual cancer care for our patients is very important. Next slide, please. That said, despite doing our best, I think the number of patients coming to our hospital has come down by almost 70%. As you can see here, this is data from our head and neck OPDs, and the number of footfalls has come down by 70%. The use of neoadjuvant strategies has also come down by around 75%. That said, in times of duress, we look at alternative solutions. So we have started increasing the use of metronomic chemotherapy in our patients with head and neck cancers. And this is one way to go, is what we feel. And this increased by almost 1.5 times in this scenario. Next slide, please. That said, as oncologists or as administrators, we might have a perspective on how to treat our patients. But what finally counts is what our patients think. This is data from a colleague in another hospital in India, where they looked at 300 patients, and it was very clear that approximately 70% of patients wanted to continue cancer-directed chemotherapy, irrespective of COVID. As you can see, most of our patients with advanced cancers wanted to continue chemotherapy, while those in remission actually were more worried about COVID than cancer. So these are perspectives that we have to keep in mind when designing strategies to combine to treat cancer and COVID. Next slide, please. At Tata Memorial Hospital, we used a multi-pronged approach to treat COVID and cancer. I will be speaking a little bit on some of the patient-directed initiatives and our preparedness per se. Next slide, please. So what we did is approximately 2 to 3 weeks before we saw our first patient, we formed a COVID action group. And currently it comprises approximately 40 people. We included nurses, oncologists, ICU critical care physicians, everyone who had a stake. Beginning 2 weeks before our first patient, we started an awareness campaign in newspapers and across the hospital, where we informed patients of the impending pandemic. We sent en masse text messages to patients to defer visits where possible and to call patients for treatment where required. We had screening camps right outside our hospital, and even for patients who come from very far away for treatment, which is seen in approximately 70% of patients in our setup, we were able to screen them and tell them that if immediate intervention was required or not. And these outpatient screening camps were the focus of our screening initially. Next slide, please. So what we did was we had a 3-layered approach for screening at our stations. We had security personnel as well as trained patient navigators, nursing staff, as well as doctors who were at these screening stations. And with the help of what we did earlier, as well as the screening, we were able to reduce hospital footfalls by approximately 35%. This is to be taken into context when we have a total of 3,000 patients a day coming to our hospital. So we were able to reduce that, but we realized that this was very exhaustive and labor intensive. And hence we changed our approach. We called almost all our patients up and tried to defer visits when possible and only included essential visits. And this was only possible because we were able to monitor the situation real time with our COVID action group. Next slide, please. So this is just a snapshot of our fever OPD algorithm. As a standalone cancer hospital, we are not trained or prepared to deal with a pandemic of such proportions, which is why right from diagnosing a patient to shifting the patient appropriately, to sample collection, to protection measures, we form protocols and algorithms at every step. Of course, from a cancer and COVID point of view, our major diagnostic dilemmas were whether fevers were due to cancer-related syndromes or unrelated, or a combination of both, which is what we came to see a lot of as we progressed through the last 2.5 months. Next slide, please. So the other place where the major point of contact we had with patients was our ward. So we started with one ward, and we currently have 3 wards with 1 waiting area, and we can admit a total of 80 patients in our wards. We trained staff who are already trained in isolation procedures, sisters and nurses who were trained in dealing with MRSA and tuberculosis were inculcated in these wards. There was a constant reiteration of standard protective processes, sample collection, donning, doffing, and almost overnight, we had to create negative pressure environments for our patients. Next slide, please. For the first 1.5 months, we were essentially just reacting to the pandemic. Over the last 3 to 4 weeks, what we started doing was to streamline management. We started classifying patients based on severity in terms of medical oncology as well as surgical oncology patients. We realized that classifying patients solely on the base of COVID as mild, moderate, and severe was not enough. And because cancer patients are a unique cohort, and I won't go into details, of course, but we mainly used antibiotics, anticoagulants, oxygen. We're also a big believer in steroids. We have not used HCQS, remdesivir, or any antivirals in our wards yet for our patients. Next slide, please. This is a snapshot of our data. And as you can see, the number of samples we tested rose almost 3-fold over the course of 1 month. And our positivity rates also increased dramatically as the pandemic has progressed. We've seen approximately 350 COVID positive patients with cancer. We've unfortunately had also 25 mortalities. It's important to note that not all of the mortalities were because of COVID itself, but were also due to underlying uncontrolled cancer status. Next slide, please. Just to look at what's happened for clinical trials during this period, almost all our sponsored trials, there's been 0 enrollment, because of the pandemic. In terms of investigator-initiated trials, as you can see, be it supportive care trials or interventional cancer trials, there has been a marked decrease in enrollment and accrual by anywhere to between 50 to 100%. And this is something that's probably going to continue for some time. Next slide, please. So from an Indian perspective, what am I expecting? What are we expecting? In India, the curve has not flattened yet, though thankfully the rise has been gradual. We do expect a spurt in COVID numbers and cancer patients as our restrictions are being eased. This is going to be there with us in India for a few months, I think. However, from an oncologist and personal perspective, as well as the feedback we're getting from patients, I think the need for treatment of cancer trumps the effects and affectations due to COVID-19, and this is based on some data that we have. Next slide, please. What we are getting from our patients is that they are definitely wary of traveling to hotspots, and where I work in Mumbai is one of the hotspots in India. In that scenario, I think it is key to maintain continuous communication with our patients, and this channel has to be open over the course of the pandemic as it proceeds. We are going to start antigen testing shortly in Mumbai, and we cannot forget the basics, that is continue to maintain as many preventive and protective measures as possible, lower our threshold for testing. One thing that we have not looked into yet in our institution is the long-term effects and how that's going to pan out in terms of psychology and vulnerabilities, not just in patients, but healthcare workers as well. And this is something that we have to look into from now on. Next slide, please. With that, I'd like to thank you for your kind attention. Thank you.
Thank you so much, Dr. Ramaswamy, for a very, very good talk. So, Dr. Ramaswamy, I'm going to start you off with the first question since you're on, and this came in during the talk, and I think you may have seen the question as it came in, but it was a question about symptoms in patients dying of COVID-19, and the question was whether you've had a similar experience where the cough becomes perhaps less of an issue, and some proportion of patients don't have shortness of breath during the last days of life, and whether this is responsive to low-dose opioids.
So this is a very interesting point, and since I look after the ward in my hospital, I have not seen this. In our patients, the one thing that we have seen is that steroids definitely helps with hypoxia and cough. But this is a very interesting point. I have not seen, and we've not used too many opioids in our setting, except for pain management in our palliative care patients in this scenario.
Okay, thank you. Yeah, I think this just speaks to how new everything is with COVID and how much we still need to learn about the symptomatology and the management of COVID. So I'm going to go now to some of the other suggested questions, and Dr. Hannon, I have one for you, and a question had come in about, is antibody testing any use to our patients in the cancer context?
This is such a fascinating question, and I think there's a lot of debate about antibody testing right now, but most of the focus in the literature at least seems to be around antibody testing for healthcare professionals, so that we as the healthcare providers have an idea as to whether it's safe for us and our risk of exposure. That said, there has been some reports, and maybe Paolo can speak to this too, about some population-based antibody testing in Germany and Italy as a way of allowing people to reduce their social distancing and to safely go back to work and do all of those things. And there hasn't been an awful lot of discussion about antibody testing for particular patient groups that I'm aware of. That said, to a degree, it would make some sense in terms of those patients that we might want to bring back to the hospital, or patients that we might want to consider restarting treatment on if we feel that they have antibodies and that they might be somewhat protected from developing COVID, or unwittingly passing it on to other people, bearing that in mind that approximately 25% of us are asymptomatic carriers of COVID. So I don't have a definite answer, but I think it's an interesting idea, and I'm sure we'll hear more about it over the next little while.
Yes, thank you. Thank you. So really good points, and hopefully we'll learn more about how protective these antibodies really are. So moving on to Dr. Scotte, we had a question come in. What do you think would be the long-term impact of the COVID-19 pandemic on supportive care in oncology?
If I can give you a short answer, there will be a long-term impact on supportive care, because patients will have nutritional disorders, will have breathing disorders, as well as fatigue. Fatigue is, in my opinion, the most important symptom that they meet. We have to be really cautious of rehabilitation. And we try to develop a program of rehabilitation, but it's really difficult because there are not so many patients, and because of when you're working in a cancer center, the priority is to cancer management and not to patients with COVID troubles. But I think that there will be an impact on patients, maybe on their disease, maybe their cancer, and probably in their quality of life. So we have to be to be altogether around the patients, to be very cautious, to monitor the patients in terms of nutritional, breathing, and fatigue disorders. So supportive care has its place around our patients.
Thank you. Yes, I think that's absolutely right, that it's going to have a permanent impact and, on how we do things for sure. So Dr. Bossi, I have a question for you. There were a couple of questions that came in about vaccines, and I don't think any of us knows the answer for sure, but I think we would like your expert opinion on really the question is, when do you think we'll have a vaccine and how this will impact on cancer patients?
Oh yes, this is, I think, is the most difficult questions that I ever heard now. It's really difficult to express any idea. Just we know that coming from the news from the WHO, we have now at the moment more than 120 clinical trials in the preclinical setting, and something about 16 candidate vaccine into clinical trial from phase 1 to phase 3. Therefore, we do expect that in some times, this time, unfortunately, I do think that it will not be less than 1 year, we will have a vaccine available.
Thank you. Thank you so much. And yeah, I think that's $1 million question that we're all waiting for an answer for. Dr. Ramaswamy, we had a couple of questions come in about the use of GCSF or Neupogen during the COVID epidemic and potential links to an increased severity of a cytokine storm in patients with COVID. Do you have any thoughts about that?
Oh yeah, so I just looked up the available guidelines, and I like the guidelines from ESMO where they say that you would want to increase the use of GCSF during this pandemic, in those patients who are at a high risk of febrile neutropenia. That said, in those patients in whom you're expecting, more pulmonary complications, you got to be cautious. But my personal take on that is that if you're reducing the incidences of complications like febrile neutropenia, you're probably reducing hospital visits and complications. So it's a check and balance kind of thing, but you would want to use GCSF in your high-risk patients as opposed to not using it for fear of complications.
Thank you. Thank you. That's well said. We have a few more questions, so I know we're at time, but I think we're going to keep going, especially because this is also being recorded and could be very useful to people at a later time too. So Dr. Hannon, we had a question come in about how to help patients deal with the social isolation that cancer patients might already have, but with the pandemic, it's just made far worse.
Yeah, for sure. I mean, so many of our patients are saying to us, now you know what it's like for us every day, like living with cancer and the fear of exposure to illness and other catastrophes. So I think it's a huge issue, especially in the older population who've been told to shelter in place, to not spend time with their families, to socially distance. And it's difficult because for many people, they recognize that their prognosis is short, and there's the quality of life aspect of wanting to be with their families while also wanting to protect themselves and other people. And what we've been doing is, trying to look at novel ways for patients and their families to communicate with one another. We were very fortunate to get some donations on our palliative care unit of iPads so that patients and their families could FaceTime. And that's been extraordinarily helpful because the staff is able to help patients who might not be tech savvy to do that. But, in the community, the same thing. I mean, I think families and their loved ones are doing all sorts of really unique and novel ways to try and keep in touch, going to each other's windows and looking through glass and really trying to connect with one another. But, picking up the phone and talking to patients and trying to maintain the connection was something we felt was really important in our clinic. So even for patients who whose disease was relatively stable and whom we might otherwise have cancelled a visit, we made sure that they continued to get a phone call from ourselves or our nurses fairly regularly just to check in and say, we're here, we're still able to support you. Please call us if you have any problems. You can't come to the hospital right now. We appreciate that, but we are still here from you, and just reach out if you need us.
Thank you. It's so important. Dr. Scotte, we had another question about how can we best support survivors who have no internet during this COVID pandemic? You're on mute.
What did we before internet? Many things. We have general practitioners, we have nurses at home, we have home care, and we have the phone call. As said Dr. Anand a couple of minutes ago, you can have the FaceTime, you can have show your relatives and your patient if you're a nurse with the phone call. I think that we have to work all together between hospital and home care. In the last ASCO meeting, we could note that Salt Lake City in the US discovered the home care with interesting results. Home care is very old. We use it in many countries, specifically, of course, in France for a long time, and it helps all the patients, specifically in the COVID situation. We have to work with them.
Thank you. Thank you so much. Another question we had, Dr. Bossi, about prophylaxis for COVID-19 and whether this should be a part of supportive treatment of cancers during this pandemic. And I know we don't necessarily have good prophylaxis at this point, but it's an interesting question.
Yes, right. We have no prophylaxis, neither for people who have not yet any contact, nor for any people that has already got a contact with the COVID patients. Therefore, we have all these some clinical trials ongoing, and we will learn something about these trials. I do not know if we will have prophylaxis then will be part of supportive treatment. What I can say is that when we perform trials on prophylaxis, we should be able to perform trials also on specific group of patients, like oncological patients are. Therefore, it is important that we cannot say, okay, this prophylaxis is good, this is not good, but this is good for this specific kind of patient that are more frail, that, for instance, as cancer patients are, and this prophylaxis is good for another group of patients.
Yeah, that's a really good point, because so often in clinical trials, there are so many exclusion criteria that actually take out these vulnerable groups of patients and don't necessarily give us the answer of how well that prophylaxis might work in these patients. So that's an excellent point. Thank you. And our last question is for Dr. Ramaswamy, and a couple of different questions came in on the same theme, and they basically had to do with offering supportive care in resource limited settings where, you know, certain things may or may not be available, like N95 masks or other drugs or things like that.
Yes, so I'll divide that into two things. One is how do we offer supportive care in resource constrained settings? The first thing is to try and preempt the need for supportive care. I think that would be most important. For example, if you feel that your patients are at a high risk of vomiting beyond prescribed guidelines, use additional antiemetics. If you feel that your patients have a greater chance of neutropenia, give them GCSF. And the other thing that we have found useful is trying to identify a local physician or a local oncologist, even if patients are not able to come to us, because of the distances people travel to come to our center. So we try and put them in touch with a local oncologist so that, their concerns and problems are taken care of. That is something we are doing. From a mask point of view, I think the shortage of PPEs and masks might become an issue in some time. It's not yet, thankfully. It has been seen that even good quality cotton masks, having high quality cotton masks has been found to be very useful in some situations, even better than the surgical masks in terms of protection. So I think there was a study done in the US, if I'm not wrong, where some of the cotton masks actually had 75% protection from these small particles. So I think that in collusion with distancing and usage of hand sanitizers would probably be the way to go when we can't provide an N95 to everyone.
Thank you. Thank you so much. So I want to thank all of our speakers for an excellent session, and also all the attendees of this webinar. I also want to acknowledge our sponsor, Alira Health, for advancing the MASCC mission of promoting supportive care in cancer. And next slide, please. If you're not a MASCC member, I would encourage you to consider joining. Check out our website at mascc.org and consider joining us in this important work. And for those interested in oral oncology, please also consider joining our partner, the International Society of Oral Oncology. Next slide, please. And also, please consider joining us in beautiful Seville, Spain, next June for our annual MASCC ISO annual meeting, where you will find more content like this, including a new plenary session on COVID-19, which is now going to be one of the themes of this meeting, and coverage of all areas in supportive care in cancer. As we say at MASCC, and one of the speakers mentioned, supportive care makes excellent cancer care possible. Thank you all, and goodbye.